So let me tell you a little bit about myself. My name's Tami Eldredge. I've been with the company over 7 years. All I do is bone stimulators, which is and so I pretty had one of the last people standing. We've had so many changes in the company.
Right.
And I started with just fracture for a couple of years, and then I moved to doing both. So I do about 70% fracture, 70% spine, 30% fracture. And I cover pretty much all of LA down to Long Beach. And I've known Anthony for years and years too. So it's literally the first week I think I started Anthony and I sat down and spoke. So I've known him for a long time. Now, are you already selling bone stimulators? Are you doing more fracture or spine or what?
More fracture.
More fracture. Okay. So briefly, you probably already know this, but I'll just briefly go over the technology. On the fracture side, there are only 4 bone stimulators. It's the BioVentus, which is the Exogen, the Biomet, which is the EBI, Orthofix, and then DonJoy. And there will only ever be 4. On the spine side, BioVentus, Exogen does not have a bone stimulator. They went after their fresh fracture indication instead of the spine. So they have a huge advantage on the fracture side because they have a fresh fracture indication. Although they only have a distal radius and a distal tibia, they seem to get them on a lot of fresh fractures. It's very hard to convert a doctor that's been used to using BioVentus to switch them over because they're used to ordering them right away and not used to having to wait 45 to 90 days or non-union. It doesn't mean you can't do it, but I mean those are, you may find you're going to bang your head. Now, if they're using Orthofix or Biomet, that's pretty easy. That should be very easy because of the qualities that we have. So what the CMF uses a combined magnetic frequency to stimulate bone growth, and a lot of people say, well, why is yours 30 minutes and Orthofix is 5 hours and EBI is 8 hours, and the way I explain it, it's just a more efficient frequency. The other two, the Biomet, the EBI, and the Orthofix use something called a pulse frequency. So they were the first ones to come out with a bone stimulator, and they pulse between 0 and 10,000. So it's called PEMF, and they take a long time to do what ours does in 30 minutes. What we found out later, about 10 years after they came out, is where's the most optimal frequency for osteoblast production. And it's not up here in the 10,000 range. It's actually a very low frequency. So the way it was explained to me in training, if you're trying to fill up a big bucket of water with a hose, and you go like this with the hose, you will eventually fill up the bucket. It's going to take a lot longer than if you just put the hose right in the bucket. So 30 minutes, very efficient frequency in bone healing. I'm not going to say that theirs doesn't work, but the problem is patient compliance. Is a patient going to wear a device 5 to 8 hours a day? And even in their studies, and I brought some information that you can look at. It's not really something I'm supposed to pass out, but it really kind of compares the 3 studies. They'll never be all 3 or 4, however many, put side by side in a study. No one will subject themselves to that. But if you look at their studies, they had quite a few patients, like a huge percentage of patients drop out just because of compliance. And that's really where you're going to stress with the doctor is compliance. 30 minutes, is your patient really going to wear the device for 5 to 8 hours? And they didn't even wear it during the study. They weren't compliant. So the chances are it's not. And if they don't, oh gosh, I'm so sorry. And if they aren't going to wear it, it's not going to work. So even though the efficacy in the studies is all fairly similar between the competition, the compliance is a huge piece. And if they're not wearing it, then the efficacy is going to go down. The efficacy on all the studies is based on complete compliance. And 30 minutes, the patient will be compliant. And even at 30 minutes, we stress compliance when we place the patient. You've got to wear it every day, 30 minutes. There's a compliance monitor on it. And not that anybody can check it. I do have physicians that have the patient bring them in so they can jot down what the compliance is. But compliance is still important either way. So that gives you a little, so ours uses a more efficient frequency, requires 30 minutes. Fracture and spine, the same thing. On the spine side, you don't, then you have the ultrasound on the fracture side. And so ultrasound is also 30 minutes, 20 minutes. It does require a lot more setup. You know, you have the gels, you have the translucer pads. My biggest selling point against the ultrasound is that it's a very small field of treatment. And so if you're gonna, I don't know how you would treat a femur or, you know, certain fractures that have maybe, you know, a larger area, a tib fib even, with small little translucer pads. Also with a diabetic patient, I always put a bigger device on, the dual coil, because you're gonna now have a nice large field of treatment. On a Charcot foot, you've got microfractures going on throughout the foot. I put the dual coil on, and you're not just treating a tiny little area that actually loses efficacy as it passes through muscle and bone. So then there's the other obvious is the windowing of a cast. Ours goes through the cast. You have to window the cast. Doctors hate that. I mean, it's very hard to get it precisely over the fracture site. You're sticking a gel and a translucer pad through. It's kind of ironic that ours isn't for a fresh fracture yet. It goes through a cast. Theirs isn't, but it's just one of those things. Also, I have a lot of physicians that will not use the ultrasound with fixation. That it just, the thought of metal and ultrasound is not a compatible. So those are the three things that you sometimes can at least get them to say, look, maybe it's not good, it's not, the ultrasound isn't as good a device for every situation.
So if somebody has a back, you know, fracture and they have, where they have pins, metal pins on their back, you can still use the bone stim for repairs?
Absolutely.
Okay.
Yeah, because think about it, in the spine, for spinal fusions, there's always metal involved. I mean, and so, so very compatible with metal. With ultrasound, I've had doctors say there's going to be sometimes even had screws shake out. So, so those are pretty good things to sell against ultrasound. We just don't have the fresh fracture indication. Now on the spine side, you don't have to go ahead.
I was going to check. So how do you sell this for patients that have pacemakers? I came across that.
Okay, and I do too. I always, because we don't go up in those really high frequencies, I've never had my bone stimulator not pass the test, but I do ask, especially with spine, I do ask the patient to take it to their cardiologist and do the treatment with their cardiologist once, just to get the sign off. And the cardiologists love it because they're not used to seeing them. But most of the ones pacemakers I come across are Boston Scientific, and I've just had a couple recently, and they pass through flying colors. So, but I do ask them to do it with their doctor. But I've never had one returned or rejected.
Do you have the cardiologist give you a letter of approval to even try?
You know, it's like, I mean, the frequency is lower than a blow dryer. I mean, so it's just something we disclose. We say, you know, if you're pregnant, or those are the only counterindications are pregnancy and a pacemaker, and it's just just go, you know, go to your doctor. And I also say I haven't had one rejected in 7 years, so I think the chances are pretty good you're going to be okay with it, right? So then on the spine side, we're lucky we don't have the Exogen Bioventus device to compete with. The biggest competitor, so you've got the EBI, which is a 24-hour-a-day treatment. I don't have a lot of doctors using that one. It requires sticky pads. It has the batteries have to be switched out every day. Patients complain about getting shocked by it. So really, the reason a doctor might be using the EBI is because they're in the OR with the biomet rep and using other product, and that rep is saying, hey, let's put a bone stem. And so that's usually how that product gets in front of a spine surgeon. Orthofix is more challenging because they do have a cervical indication, meaning theirs does fit over the cervical a little bit better. Although I have had, all the doctors I work with have tried Orthofix, and they still feel the 30 minutes over the 8 hours is a benefit. And they still have patients complain about the one around the cervical. It pulls on the neck, it is uncomfortable. 30 minutes, and we have, and it just came out, have you seen, John, the new design of our?
No, I have not. A lot of the doctors that I worked in the past, they use the spinal on the neck then, or fix on the neck.
On the neck, yeah.
Mm.
So, and, I bump up against that. I'm still able to oftentimes get them to still go back to just using ours because they will start to get complaints about that. We did redesign it. You probably are just now starting to get
I
them.
remember you were telling me about
So
it.
in your next batch or so, and we'll get the new brochures. We still can't build a device that looks like it goes just on the cervical because we don't have the cervical indication. But it does contour more now. You can trim it, and my technicians trim it, and so it doesn't look like it's a belt around the neck. And it trims really nicely. It contours to the neck. I have a patient just yesterday tell me that they do it while they're doing they do their treatment while they're doing the dishes. So this other one wasn't as conducive to like really walking around, but now this one it looks very similar. It's red and it's got a padding on it, and it does contour. You can contour it more to the neck and the strap, and then put the remote on here. So. It is recognized by Medicare. I mean, for cervical spinal fusions. I mean, very rarely do I get a denial, but if it's a denial, it's a denial for everybody on cervical. It's not saying, oh, we'll take Orthofix. So if they don't take cervical, they're not taking Orthofix either. So we're in the exact same category. It's a little bit more challenging, but still doctors do prefer the 30 minutes a day. And if you talk to people.
Yeah, I think it'd be helpful. I mean, even if it's not just for you, but just for everyone.
Yeah,
else.
so the reason fracture is, I'll start with spine. Spine is less challenging because the criteria is simple, and the goal is to get a spine surgeon to use a bone stimulator as protocol on multi-level spine, not to have the surgeon okay each order. It's like, the goal is to have the surgeon tell the surgery scheduler, I want a bone stimulator on all my 2-level fusions. And then maybe branch out to a failed single level or a single level with a risk factor. But when you can convince a doctor that this is protocol for 2 or more level fusions, that's golden. I mean, because now he's not having to think every time. He's checking it right off with a brace and a cold and a bone stimulator. And if you can get that little put on the box, then that's a good thing. For Medicare we're requiring more things on Medicare files right now. The changes we've had recently is that, so to get them to, initially I asked for the face sheet, insurance information, and a report. So either a CT report, an MRI, a doctor's report, but for Medicare, we are now starting to require a signature on that. We didn't used to before. I just want to help you guys make sure you're getting reimbursed, because we're finding that we weren't getting reimbursed without a signature on the initial report and on the op report. It can be an electronically signed signature from the doctor, but a signature on both are now being required from us, and a CMN. And the CMN for the spine has to be dated between the date of surgery and the date of placement. That the CMN has to be dated between there. So MPI numbers now are required on the RX and CMN.
Right.
So these are just some of the things that you probably already know, but I'm just letting you know kind of the changes we're making. Bone stimulators not for a failed fusion, a failed single level, it has to be 9 months out. Blue Cross, some of the other insurance is only 6 months out. So you just need the original op report for a 1-level fusion. 9 months later, a report saying that pseudoarthrosis or that it is not fused. So that's a way of tapping into some single level. Medicare won't look at a risk factor, but most other insurances will. So you can also do adjunct to surgery at a single level with diabetes, smoker, steroid use, obesity. So I like to not overwhelm a doctor, but you start off with the 2 levels, and then you start understanding what surgeries they have going. Oh, look, you've got a 1 level, and this patient, is diabetic. They're going to probably struggle with the healing. So that's the criteria for spine, which is pretty cut and clear. It's the fracture that you're doing. A lot of is a little bit more challenging. Most insurances are 90 days, but, Blue Cross is 45 days. So you need an initial x-ray note 45 days later saying that incomplete healing, fracture line's still evident. Non-union is the best, but some doctors don't like to write non-union. So if you can at least get them, they can't put, good callus formation and expect a bone stimulator, obviously. So we have to kind of get them in the groove of like what is needed. If you want this patient to have a bone stimulator, I'm going to need the right, and a lot of reps don't wait for an order. Like they look at a fracture order and say, oh, this one's crap. I'll hold on to it and write down when that patient meets criteria. Call the patient, say you now meet criteria, and have them set their appointment up around like not 2 days. With Medicare it has to be 90 days, but right at that time and talk to the doctor and I even go to those appointments and say the patient now meets criteria. So it doesn't necessarily mean it's a bad order. You might just have to wait for it. And if every month you have 2 or 3 you're waiting for, that's a good thing. Then it's just a matter of getting the patient back in for another set of X-rays. And so the challenge is to not put submit a file unless you really understand the criteria of the insurance. Because once you get a denial, going through an appeal is very difficult. I don't see a lot of appeals overturned. And so what I think happens is reps don't understand the criteria, they just get frustrated with fracture, and then they don't want to do it anymore.
Right.
Yeah. So it's just understanding, and I'm more than happy to be called at any time. For you guys to increase your business is me increasing my business, so I'm more than happy to, be at your disposal for questions on criteria and on insurance, and, are you guys you guys don't really do HMOs either, do you?
Well, it's more of a billing question. I believe they do both. I believe they do some HMOs. I'm not sure how many though.
And I know that there's insurances that you're not contracted with that I know certain, like JD refers them over to me and you guys get a referral on those. So don't walk away from anything. The chances of me being contracted is pretty strong. So I do get referrals from you guys. And I'll just email you saying this is what I missed. I'm not going to call your doctor. I'll say to you, we're missing this note. This one doesn't. Yeah, this is what we need. Blue Cross doesn't cover stress fracture. We need to get stress out of there. So things like that. That a file that looks really frustrating, I might be able to just tweak it for you and get it through the system, either through DJO and give you a referral, or just help you get it through your system. So, and I think that's I think I covered.
You covered a lot, and that's really the main thing. And also too, which I know we talked about, is just like what if you have like a breakdown or like a cheat sheet as to this is what you should use for this body part, this is what you should use for that. This is so these are our there's not that many. There's really basically 3. Because this one comes in 3 sizes, and I don't even think you stock the 2 bigger. It's just the ones that...
So the dual coil is the boxier, is this boxier one. Okay. That one I use for an ankle, obviously. For a 5th metatarsal, for a patient that's casted, you're going to use the dual coil. So this bottom piece slides in and out, so they can use it with the cast, then slide the bottom piece in, and I think your techs probably know that when they get the cast off. And it could be used for a radius as well. So once you have this in front of you, it's kind of obvious. Then this little one here, I tend to often put on a 5th metatarsal because it just goes right over that 5th metatarsal. I'll put it fits really well over a clavicle. My athletes tend to like the little. If a patient travels a lot, you want to maybe put the smaller one on. An elderly patient may not want to bend down. Maybe you want to put the dual coil so that if you feel like they just want to plop their foot in.
Right.
Like I said, with a diabetic, I put the bigger one on because you're treating the whole foot. Maybe if a patient is osteoporotic or arthritic, I'll put the bigger one on so it's treating the whole foot, not just a small area. So those are really, and then this SC2 is really not, maybe for a femur here.
Okay.
And if it's not going to fit, then we go to the SC3 and 4. And I probably only put an SC4 on a severely obese person because
So
to go,
big.
yeah. And I have, maybe three or four in my career. So really, you're looking at the dual coil for most,
Okay.
the SC1,
Mhm.
you know, clavicle, arm, and then it gets a little tricky with the humerus. We will do, my tech likes to put the SC2 because it kind of goes around here.
Mhm.
So that's the only time the humerus is a little more tricky because if you're up here on the shoulder, it's a little harder to get to. Clavicle's easy, here is easy, here is easy, but right here, well, there's a way, and they showed in the instruction book, and if your tech needs to talk to me, but that SC2 can strap around here.
Got it.
So, but, I mean, I think when you have this in front of you, it becomes more obvious what you're gonna use on the patient. It's really cast versus no cast.
Right.
I mean, some people might use a dual coil on all their fifth metatarsals. I kind of go back and forth. You know, if I can tell it's an active patient, they're not going to take that dual coil with them on an airplane probably
Right.
very often.
Exactly.
But they will take the little one, and women can throw it, you know, in my purse, and that one's, you know, really easy to use. A sesamoid, I'll put this little one on too. Something that I just want a really concentrated area. If they've had a lot of surgery, I like to put the dual, because then I know they're getting hit from all angles.
Quick question, so say patients that set up at, 3 o'clock in the afternoon. Most of the time my PSR goes out there and sets them up. They have to wait again until 3 o'clock to do it the following day? No, right?
No, so I'm glad you brought this up. So it only has the ability to turn on once a day. It resets around 10 o'clock. I used to say midnight, but then with the time changes, and I don't know how these things know when they're time. So now I just tell patients try to use it before 10 p.m. You don't have to wait a 24-hour period. You just have to get your treatment in every day. So if you use it at 9 o'clock one night, you can use it at 7 a.m. the next day, 3 o'clock the next day. So yeah, so it's really important that the tech doesn't say they have to wait 24 hours, because then they're like, oh, I missed it, and then they don't even try.
Right.
So and I do stress compliance, even though ours is easy to use and a short amount period. It's because we want to get good results. We want the doctor to continue prescribing. So, and we're putting this in the patient's hands. So we really want them to understand. Now it does show a battery sign when the battery needs to be changed. They all come with, I think, 6 to 8 batteries in the container. They're just a 9-volt battery, and the back pops out. Battery lasts about a month. I mean, there's really not a lot of. Now, if you have, obviously we're going to replace. We will replace a device if it's not working. And what I'm doing, because we've had so many changes in our company, I'm just having my tech grab. If it's been within the 3 months, or I'm just going to switch it out for you and send it back out of my, because all your stuff's coming out of my inventory. So rather than you go through customer care, because I don't even know if we have a real valid customer care anymore. So I'm kind of taking it under my own hand, because I really have no one really managing me anymore. I'm kind of out there, so I have a lot of flexibility, I should say. So, like I said, I mean, I've been working with Tina Ken a long time. I've been with the company a long time. I value Simulator. I'm not, naive enough to think that that's the case. But if I can somehow increase my volume with you guys, just out of understanding some of the really true benefits of this device over some of the competition.
Yeah, no, I think that's perfect, because I mean, especially getting it together, I think more that it's out there, I think people will start.
Yeah, and knowing that I'm available. I mean, I know, I just want you to.
I think we do really well using the bone stem. I think more your like anybody else's.
Yeah, and then that's good, because I want to be available to you. I mean, if you can't get hold of the rep, or you don't feel comfortable about talking about it. I mean, that's why if you can be kind of a bone, you have to be an expert, but at least be able to understand the criteria and the fracture side. I'm very impressed by the amount of fracture you purchase, because that's a very good indication that your reps because not a lot. That will put you at a huge advantage, because not a lot of distributors understand. They don't even.
Plus, I think you've been, it sounds you and I, Del, you've always been really helpful. So that's always makes it easy for somebody. We try and get hold of somebody and return their cost.
Thank you. And that's Bone Stimulator 101.
Perfect. Great job.
In a nutshell, and anyone that wants any further, like if you need a little bit more depth in the clinicals, if you need a little more depth with the competition, I can provide that too. But I didn't want to get too deep, because you guys, it's not like you don't
We're-
have 1,000 other products to be working on.
Yeah, exactly.
Okay?
Well, perfect. Well, thank
Okay,
you